Well, I'm going to go ahead and put the link to the agenda in the chat for everybody. I know I can see a few folks in there looking at it right now, but if you don't have it handy, I'm just sending that out in case you'd like to get it pulled up, since I am going to navigate away from this screen share here. And I'm actually going to let Shelley Mell, Executive Director of our local affiliate of the Arkansas Community Foundation here in Faulkner County, do a couple of announcements before we get started. And just to give everybody kind of a lay of the land, this afternoon, we're going to have 3 speakers talk about the big picture of COVID-19 in Arkansas. So the Arkansas Center for Health Improvement, the Arkansas Asset Funders Network, and Arkansas United. We have 3 wonderful speakers speaking on behalf of those groups about these topics of the big picture of COVID-19 in Arkansas, COVID-19 and ALICE, individuals and families, and then immigrant communities. So we're very much looking forward to all 3 of those perspectives. And have a few different announcements to share with you all throughout the afternoon. The one that I want to let you all know about is just that this is kind of the official kickoff of the workshop series that UCA does in collaboration with Arkansas, with United Way of Central Arkansas. And the next one of those is going to be later this month, and it is focused on fundraising during COVID-19. So a really important topic for a lot of folks. And then I am going to end that screen share and pull up a little slide from Shelley. And Shelley, feel free to go ahead and unmute yourself.
Hi all. Thank you, Leslie, for letting us just give a couple quick updates of information from the Arkansas Community Foundation. First, a couple resources. Most recently, there was a COVID-19 impact study done about Arkansas nonprofits, and probably many people participated in that. And the full report is available online at the Clinton School website. And that was a collaboration with the Clinton School, UALR, and the Arkansas Community Foundation. Another resource is the Aspire Arkansas data. And I wanted to make sure everybody here knew that data points have been updated, not all of them, but many of them. And again, this is another resource that you can use when preparing for grants or making cases. Use it on your website, however you find it most useful. And leading into, on January 10th, applications will open up for our local Giving Tree. Affiliates choose whether they want to participate in the grant cycles, either in the fall or the spring, and ours will be in the spring. Giving Tree is typically an unrestricted grant process. We will also be opening up for grade level reading and for Stop Hunger grants. And so those applications will be open on January 10th. Our hope is that by sometime in early December, we will have a list of priorities for what we're looking for in the grant process. And of course, we will be using the Aspire data and the nonprofit report to help guide our grant process as we move forward. For those of you who operate in multiple counties, please look at the Arkansas Community Foundation map and see if there's an affiliate who will be participating in the grant cycle in the spring, and feel free to apply for those. So Leslie, those are my quick 3 updates.
Great, thank you so much. All right, so we'll go ahead and get started with the program here. And for those of you who I don't know well or who've just received emails from me, my name is Leslie Graybiel. I'm the Director of Service Learning and Volunteerism at the University of Central Arkansas, and am glad to have the pleasure annually of helping to organize this event, although I'm sad that this year we can't feed you, because that's normally what we like to do, is feed everyone. But hopefully next year we'll be back to doing that. So just want to say welcome on behalf of UCA and of the entire Division of Outreach and Community Engagement here. And then Pete, do you want to say a word of welcome on behalf of Hendrix, our collaborators and co-conspirators on this?
Yes, thanks, Leslie, and I really appreciate all the work you've done to organize this. Welcome, everybody. We look forward to learning from each other, and I hope, wish you all health and safety during this difficult time.
All right, and then Jennifer, does United Way have any announcements or words of welcome that you all want to share in addition?
Sure. Hi, I'm Jennifer Boyette, Executive Director of the United Way of Central Arkansas. I'm here with my colleague, Laura King, who's our Agency Engagement Director. We are just so pleased to be here and be a part of this event. So thank you, Leslie, for all the work that you and everyone has done to pull this together. Just a quick announcement from the United Way. We will have our mini grant cycle kicking off 1 week from today on September 15th. And that will be on our website at uwcark.org. You can find our grant page and you'll be able to find that link. So if you are not a funded agency partner, you have an opportunity to apply for up to $5,000 that will be awarded we'll have 20,000 total, but we'll award up to $5,000 in grant. So thank you.
All right, thanks. All right, so just one more just word of kind of introduction before we get started with the program. So for those of you who haven't attended this event before, we typically like to bring in some speakers who can talk about topics of mutual interest to nonprofit leaders here in Conway and throughout Central Arkansas, as well as to, excuse me, community engaged faculty at our colleges and universities here in Conway, and open it up to provide some opportunities for collaboration. And so that's what we're getting started with, is just setting the stage, and then we'll have some more interactive elements and local perspectives just a little later this afternoon. But to get us started, I'd like to go ahead and introduce Dr. Joe Thompson, the President and CEO of the Arkansas Center for Health Improvement. Some of you may have been watching ACHI's updates weekly throughout this time, and we really appreciate the resources that they've been providing and appreciate you all being here today.
Thank you, Leslie. Can you hear me okay? Great. Well, it is a pleasure to be with you all in your meeting. We do appreciate those joining us on the call. My colleague, Michelle Kitchens, is going to help me here and run through a little brief update on where we are. Unfortunately, I think it is a topic of interest to us all. I wish we did not have that topic to be interested in, but I think it's timely, and I think it's going to be with us for a while. So I'd like to just run through this and then be glad to answer any questions. Anything's fair. There's a lot that we don't know. Just a little bit about our center first. We've been around, we're in our 21st year. Our mission is to be a catalyst to improve the health of Arkansans through research, advocacy, program development. We predated the College of Public Health, trying to improve the health of our citizens, not just the health care system. And we've really turned a powerful set of folks loose to transform data into information that then hopefully can influence the policies that we put in place. And we look forward to partnering with your organizations. If you've got folks that want to come experience with us, that would be great. Right now, our priorities, we're trying to help our health care system offer the highest quality and most accessible care. We also have issues in our communities, particularly in the realm of the systemic racism that we have and the drivers that it has on negative effects for our low-income communities and communities of color. And then obviously our individual choices around leading a healthy lifestyle, avoiding some of the challenges or the traps that we can fall into. So these are our three kind of balanced set of priorities. We were rocking along, trying to get fluoride in the water and insurance coverage for folks. And then suddenly this new virus. It wasn't the fact that it jumped from a bat or a monkey to the person at first. It's when it jumped from that one person to the next person that we started having a challenge with, a new pandemic. This is actually a picture of the COVID-19 virus, the coronavirus. The word corona comes from the crown, the red crown of the spicules that are on the outside part of the virus here. And this pandemic, this virus, jumped into the human species. None of our immune systems had ever seen it before, so we don't even recognize it for the first few days when we get infected. Now, the United States, unfortunately, is leading the world in terms of the number of cases. We've had over 6.3 million cases, 189,000 deaths. We only have 4% of the world population, but we've had 25% of the cases and more than 20% of the deaths experienced in the entire world. And so this really is, I think, when we get to the end and we look back, this will be a dark mark on our responsiveness as a nation to what was a new threat in the world. We're making some progress. 2 months ago, July, we were having 17,000 new cases a day in the United States. You'll see in the months of August and September, after that spike in July, because we are taking more seriously the threat and probably more consistently implementing the measures that we know work, the physical distancing, the masking, the improved hygiene. We're down now to about 40,000 new cases a day. Europe, which has a third more people than we have, we're rocking along there for a long time with only about 5,000 new cases a day, because they did achieve high levels of distancing and masking. As they have opened up and started to have more travel, they have lost some of that control. So they're now approaching 26,000 new cases a day. And again, this is just an incredible impact on our nations around the world. We've passed 65,000 cumulative cases. We now have about 6,000 active cases. We've dropped in terms of the number of people that are actively hospitalized or on ventilators, but unfortunately we've crossed the 900 death mark. You see the darker blue counties here are where we have more cases. This is actually driven largely by population and then by outbreaks within those populations going forward. We can go to the next slide. We are in a situation where our state and those other states around us are largely defined as uncontrolled spread. This is with a positivity rate on the number of cases or number of tests that we do each day of above 10%. So if for every 10 tests we do, we find a new infected person. That's kind of the definition here of uncontrolled spread. And we've been in this mark for a while. There are kind of 4 important questions that have come out that I want to emphasize for you. First is, how readily does this coronavirus spread? This is the R0, or the number of people an infected individual is likely to infect. We do know how this virus spreads. It's a respiratory virus. It spreads by respiratory droplets from an infectious person being expressed either because you are talking or breathing or you sneeze, and then basically a person around you gets it in their eyes or in their mouth or breathe it in, and you get infected. And right now the R0 is about 2.5 people are infected from every infected person. That's why we put the barriers in place. The case fatality rate is proportion with the infection who die from it. This is going to end up being less than 1%, but 1% of the US population is a large number. And so it is a relatively fatal virus because we have no immunity to it. The next challenge we have is who's most at risk. And we clearly know, at least from the early impact, that older individuals and those individuals who have several conditions that make them less able to fight the virus off do have the most negative outcomes. And we'll come back to that in a little bit. And then what can we do to limit the risk? I mean, there are individual actions. This is our hand washing, our physical distancing, our wearing a facial covering. There's collective action, which is what we did back in May and June, and are still having some restrictions put in place. This is when we closed down bars, when we closed schools, when we did collective efforts. And then their public health actions. This is the contact tracing to try to identify who might be exposed, active testing for them. And then obviously our end goal here is to have treatments and vaccines to be able to protect individuals. So these are kind of the 4 questions that all of our actions and efforts are trying to take control of because of this new threat, again, that the human species has never seen. So if we go forward, you know, we were worried early on that we were going to overwhelm our healthcare system. And so this, you know, flattening the curve to try to avoid the purple area where we would not be able to take care of people. And so we have flattened the curve. Unfortunately, when you flatten that curve, it makes it last longer. So we're going to live with this for a longer period of time than if we had just let it burn its way through our cities and our families. But we would have overcome the capacity of our healthcare system in terms of hospitalizations and ventilators. At 500 hospitalizations, that's about 10% of the bed capacity in the state of Arkansas. On any given day, we have about 5,000 people that spend the night overnight. So 500 hospitalizations is about 10% of all of the bed capacity and the ventilators that go with that. So this is the goal that we had for flattening the curve. You can see when first of all, Arkansas probably benefited by, you know, not having an international airport, not having the international travel that New York or San Francisco or Los Angeles had. So early on, we did not have much. And then in April and May, as you all remember, we pretty much locked down. As we opened back up in June, you started to see our number of cases grow. And actually there after the 4th of July, we were on a pretty strong upward trajectory. The governor put in the facial covering mandate, and we saw that come down a little bit. We've seen some spikes here at the first part of September. It's not each day's number that I think is the most important. It's kind of the average for the week. And so that's why we've shown here the rolling average for all cases. That includes the prison population that's in orange and also the community cases that's in light blue. Those are that occur in our community statewide. And this now is in every community statewide. There are no communities that are spared. Here again, where the number of active cases, an active case is from the time that you're positive for 14 days, or if you're in the hospital, it's for 21 days. So these are the number of active cases here. You see, we were on a very steep climb in June. We flattened that out in July. We brought it down in August. And I'm worried that we're on an upward trajectory again, starting now early in September. These are the number of active cases. On the next slide, I think, are the number of hospitalizations. And again, you can see we have flattened that out in August. So, you know, we've done a good job regaining control. We're still at a much higher rate than we were before. And I think we're learning more about this virus. It's not just a respiratory virus that infects your lungs. We now are seeing it affect other organs and maybe even having some longer term damage that we'll get to in a few moments. So we have hospitalizations. We started out saying, how long does it take us to get to the next 100 hospitalizations? And you can see there, you know, when we were locked down, it took about 50 days. And then when we opened back up, it was 18 days in June and then 12 days, 19 days. Luckily, since July 24th, we've not gotten to the 600 hospitalizations. So this is good. When we look at the number of ventilators on the next thing, this is also, we see fewer people that are having to be assisted with mechanical ventilation because their lungs aren't working. This in large part is because we've learned how to treat people more effectively with dexamethasone. That's a steroid that many of you may have gotten a shot of when you had a bad case of poison ivy. But basically this virus can rev your immune system up. So not only is the virus causing harm, but also your immune system can go into overdrive and cause harm. And so we're learning better how to manage people. So this is actually resulting in people on a ventilator for shorter periods of time, which results then in the number of patients on a ventilator on an average each week being a smaller number. So about 80 to 90 folks today. Now the deaths, unfortunately, these are the number of deaths each week moving forward. And over the last 3 weeks, we've had more than 100 deaths each week. And so this is a number that unfortunately I think is starting to claim more and more lives. On the next slide is the number of these are we took people who had positive tests and we looked in the state's all-payer claims database to say, okay, what conditions did they have before? And then we looked for bad outcomes. So hospitalization, or being put in an ICU, or being placed on a ventilator, or dying. And these are the conditions that increase your risk of these bad outcomes. If you have kidney failure, you're 60% more likely to be hospitalized, you're 80% more likely to be admitted to the ICU, 140% more likely to be intubated, and twice as likely to die, 100% more likely to die. If you're immunocompromised, you're on cancer therapy, you're on high-dose steroids. If you have diabetes or you're obese, much higher likelihood of bad outcomes, congestive heart failure. This is one that's kind of interesting. If you have memory problems, you're 50% more likely to die, and it's an even higher percentage if you live at home. But you're not more likely to be hospitalized or be admitted. We think people don't recognize that they have symptoms, and they're actually more likely to die if they're living alone with memory problems, 50%. So if you have loved ones or family members, community members that you think may have some memory issues, it's time to check in and make sure that they're doing okay on a periodic basis. So we're tracking these conditions on the left side with the bad outcomes in the table to try to help people know, okay, if I've got a loved one with one of these conditions, I may need to try to safeguard them in the coming months and try to minimize their exposure even more than we have historically done so over the last few months. So from these conditions, we actually did, how long did it take us to get to the next 100 deaths? And you'll see it took us about 70 days to get to the first 100, 30, 21, 19. Just in the last 3 weeks, 4 weeks, we have skyrocketed in the number of deaths. It only took us 8 days to go from over 700 to over 800 deaths in the last week. It was 11 days, the 3 weeks before that. So we are now starting to, while we're having fewer people in the hospital and on ventilators because we are better able to treat them so that their hospitalization is shorter, the number of deaths is escalating at a very significant pace. And I think this is a cause for significant concern in our communities. So if we go forward, you know, I mentioned not only are the deaths, but we're starting to see some of the damage caused done out of the published in JAMA, where they looked at 100 recovered patients that had had COVID, and they looked 2 months later at their hearts. And about 2/3 of these had not gone in the hospital. They hadn't been ill enough to even go in the hospital. About 1/3 had gone in the hospital. But 78 out of the 100 had heart damage itself. 76 still had elevated biomarkers, meaning that they were having ongoing damage similar to a heart attack. 60 had actual myocarditis. A different study that looked at people who had died showed 41% of the people had had the virus infecting your heart itself. So again, we're starting to learn more about this virus, and it's much more potentially damaging than I think we had originally thought. And I think this is what may be leading to some of those deaths in individuals that, you know, had previous problems, but the virus actually pushed them over the edge, and we're seeing a larger number of deaths going forward. Now, going forward, just to do a little bit of immunology 101, this is a new virus, and it infects us, and we feel fine. We don't even recognize that we're ill, and we can actually spread the virus. About half of us over time start to feel sick. We get a fever, a headache. We may lose our sense of taste or smell. Our immune system kicks in, and it fights the virus off most of the time. Again, about 1% of folks really have a bad time with it. After a while, our IgM antibodies go up, but these don't last very long. And then our IgG antibodies go up. And the open question that we have is, how long do these stay up? A vaccine hopefully is going to make your antibodies come up and stay there. But what we don't know is, over time, are these going to degrade and we lose immunity, or do we actually get immunity that lasts a long time? And what's being tested now in the vaccines is, can the vaccines trigger that immunity without us being infected, and can they have us have lasting immunity over a period of time? It's unknown now whether this is going to be, whether the vaccines that are developed are going to be like the measles vaccine that lasts throughout your lifetime with maybe one booster later on, or is it going to be like the flu vaccine where we have to get an update each time? So if we can go back, Michelle, to the previous slide there. I just want to go, no, there you go, on the isolation and quarantine. This is a very tricky virus. And if I had been able to design a virus, it was going to be harder for folks to understand why we're doing what we're doing. I don't know that I could do it. Because our immune systems have never seen it, we can be infected and infectious, and only about half of us are ever going to get symptoms. So if you have a positive test, then if you don't have symptoms, you're supposed to stay isolated for 10 days from the positive test. They're saying 14, it's usually about 14 days total run, but if you have a positive test, the test is usually positive at about day 4, so plus 10 days, that's when you should stay isolated. If you're with symptoms and you're positive, then it's 10 days after your symptoms started, and then your symptoms have to be gone and no fever for 24 hours with no Tylenol, no Advil. So if you have symptoms, it's 10 days from the start of your symptoms and they need to go away. So if your symptoms last 14 days, it's 14 days plus 1. If it's 20 days, it's 20 days plus 1. And if you're hospitalized, you probably had more of a load of the virus, and so they're recommending that you stay isolated for 20 days if you have a positive virus and you were a positive test and you had those symptoms. If you're exposed, but you don't know if you're infected, this is where your quarantine comes into effect for 14 days. That's because it'll take about 4 or 5 days for you to get tested and for the test to be positive, and then it's the 10 days. So that's where the 14 days come in. And if you're exposed, it really doesn't matter what the test result is, because the test that we have now, you can't count on the negatives being true. There is a false negative probability here, so that if you know you're exposed, it's 14 days of quarantine regardless of what the test result is. So basically, this is a pretty tricky virus. It's about a 10-day isolation if you know you're positive from a test, and it's 14 days quarantine if you know you've been around somebody who has been positive. And of course, the recommendation now is if you know that you've been around somebody positive, is to go get a test at about day 4 or 5, because if you're positive, that starts the contact tracing for the people you've been around before you got exposed. So this is where the contact tracing comes in. And this has really been difficult, I think, because of the moving parts here. But it's a long effort. Now, the mask recommendations, I think, are very strong. We know how this virus is transmitted. It's respiratory. And masks help prevent that asymptomatic spread where people are infected prior to having symptoms. And actually, now we know about half the people that become infected and are infectious never even know they are. So that's why all of us need to wear a mask. We know this virus is from respiratory droplets. The 6 feet of spacing is because gravity does work on those droplets, and so gravity will pull them to the floor and not have them breathed in or come in contact with others. So you should wear a mask when you can't guarantee that you can keep that distance. And then, the last bullet here is pretty straightforward. The hygiene is still important. It's important to wipe, common surfaces down. These are our best protected measures to keep from spreading this virus. On the next page, we got a little bit of a graphic here. The infected but asymptomatic person doesn't even know that she's spreading the virus. The person who's wearing a mask probably has a little bit of a protection because that mask is going to keep him from breathing those particles in, but the person who's not wearing a mask is maximally exposed. By wearing a mask, on the next slide, you see how much it cuts down on that infected person from spreading the virus. Now, we've actually tested different masks to know which ones work. And on the next page is a whole profile of masks. All of these work except for 2. The bandana, the Bonnie and Clyde bandana, is no better than doing nothing. And actually the gators that come up and that are real close to your mouth are actually worse than doing nothing. Now, why are they worse? They're worse because it's so close to your mouth that when you breathe out, it's making the respiratory droplets fractionate into even smaller droplets. And so they travel farther and they stay in the air longer. You need a mask that has a little air pocket to capture your respiratory droplets, and all of these work except for the gaiter and except for the bandana. So pick your mask of choice, but don't let it be a gaiter, don't let it be a bandana. All right, if we go to the next slide, we've got different, this is the best information and evidence that I have that masks work. This is a study that came out a couple of months ago, and then the CDC went in and actually tested folks. There was a women's hair salon that 2 of the hairstylists were actively infected and infectious. They were potentially spreading it to other people. But they were wearing a mask, and all of their clients were wearing a mask. And of 139 folks, nobody got infected. So this shows how effective those masks are, even in close contact, which in a hair salon is going to have conversation, it's going to have interaction. So this is the best evidence that I have when people say, well, do the masks really work? They clearly do, and they clearly break the spread of the condition. Now, cleaning, disinfecting, the virus can live on surfaces, so that's why you need, if you've got frequent turnover, to wipe it down. Routine soap and water works, disinfectants work, and again, the reinforcing of your hand hygiene. I would encourage you, anytime you leave your house, anytime you come back to your house, just make it a practice of spending about a minute in the restroom or at the kitchen sink washing your hands. We're making some progress on the compliance. Our board, my policy board, came out with, this predated the governor's mask mandate, but I think it's important for employees, customer visitors to wear facial masks. There are some simple screening questions. Fever, cough, shortness of breath. If you lose your taste or your smell, you have COVID. I mean, about 50% of people that have COVID lose their sense of taste or smell. And so that's a sign or symptom that, take it seriously if for some reason you do that. On the next slide, we also have, recommendations, verbal announcements. At my work, we've got signs up, and it's easy to just let your guard down. So, having verbal announcements, having signage, making sure that the number of people in a room are minimized, have it written down so that everybody's playing by the same playbook. And then as we learn more about the virus, change what we're doing so that we are optimizing our protections against this virus. I think I've got treatments on the next slide, maybe. Michelle, can you go forward for me?
I'm trying. Hang on.
All right. I didn't know if I was frozen or if you were frozen or if
No, I'm frozen. Okay,
right.
Here we go.
Well, we have 3 different types of tests. Just to go there, there's the molecular test. This is actually looking for the DNA and the RNA of the virus. That's the one that is a nasal swab that gets sent out. We increasingly have the rapid antigen tests that are available in doctors' offices or in some of our colleges. And then there's a blood test that actually looks for those antibodies to tell if you've already been infected. The first 2, the molecular and the antigen test, they have very good performance if they're positive. They say they're positive, you have it. What they don't have is they have a relatively high degree of false negatives. And it's not so much that the test is negative, but the virus may not replicate in your body up to 10 days. So you could get a test early, it'd tell you you're negative, but you're still infected. So that's why if you've been exposed, that's why regardless of the test, it's that 14-day isolation period from exposure. Now the serologic test, the antibody test, doesn't help you know whether you're infected today, but it does let you know whether you've been infected in the past. And I'm increasingly finding folks that go give blood and they are doing an antibody test when you give blood, and people are finding out, hey, I've already had the COVID because I have an antibody. If you have an antibody, your body was exposed to it. And even if you never got sick, your immune system fought it off in the past. We are having some pop-up, I call them yard sale labs that this is a sign of, and I would encourage everybody, if you're going to get a test, go to a legitimate, your provider or a legitimate testing source, not to one of the drive-by labs that are asking for $100 to get your lab test in your backyard garage sale. So going forward, Michelle, if I can. These are our treatment updates. We do have the convalescent plasma. These are people who have been sick, their immune system has fought off the virus, and they have donated their plasma that then can be transfused into other individuals. It's usually reserved for very sick individuals that are having a hard time with the virus, because there are some reactions to the plasma. We have remdesivir, which is a drug that has been shown to shorten the hospital duration and reduce the death rate about 20%. I've got hydroxychloroquine up here. It seems to be the zombie drug that keeps trying to come back. We've got strong evidence that it really does not do much good, although there's political support for its broad use. And then the dexamethasone, which I think is what's given us our best benefit right now, which is helping our immune systems or helping our clinicians be able to titrate how active our immune systems are. You want your immune system active to fight the virus, but you don't want it going into hyperdrive and causing your own body damage. So these are our treatment updates. I wish we had a knockout drug. We do not. So I know the pharmaceutical industry is looking for one, but we don't have a drug that we can safely give people and know that it's going to actually cure the coronavirus at this point in time. So we're also working on vaccines. The traditional program would have taken about 4 years to get a vaccine through. You got to develop the vaccine, then you have phase 1 safety trials, then you have phase 2, they call them efficacy trials to say, do they stimulate the immune system? And then they do a large scale trial in phase 3 to say, is it safe for a large number of people, and does it trigger the immune system to develop lasting immunity over time? Well, they've shortened that, and actually, by accelerating these different phases, we're now in the midst of 3 large-scale trials in the United States for a vaccine that could be available as early as the end of this year. I think it's unlikely to be much earlier than the end of this year, because you have to give people the vaccine and then see whether their bodies react and create an immune response that lasts. If it doesn't last, then there's no real benefit of having the vaccine. So it's going to take us a few months here to be able to get the vaccines up, running and tested. Right now, worldwide, if you go to the next slide, we've got about 100 plus vaccines that are in development. We've got 24 vaccines that are in that phase 1 safety testing. We've got 14 that are in the efficacy trials. Worldwide, we've got 9 that are in the large scale, 3 in the United States, 6 overseas. And there have actually been 3 that have been approved for use, but they have not gone through the safety testing. One of these was developed by the Chinese Military Medical Academy to be given to the Chinese Army. And I think half the Chinese Army has been given that vaccine. I don't think any of us want to sign up for those 3 that have limited approval because of the developmental pathway that they've been on so far. Don't have any yet that are approved for broad full use nationwide. We go to the next thing. We at ACOG have started using some of the health department's data to publish where it is most concentrated. So the darkest zip codes here have more than 100 active cases per 10,000 residents. So that's more than 1% of the people in those zip codes are actively infected today. And so we publish this each Friday and it is available. So this is a way that you can track where you're going or where you are and what the risk is in your environment. Again, it's in every zip code, but the darker zip codes here have a higher level of community risk. Now, we've all gone back to school, or at least have thought about going back to school. This has been a big source of anxiety, and it continues to be a significant amount of uncertainty. We've looked at school districts and also are publishing on Thursdays the risk of school districts. This was an estimated number of infection. If you have 500 people, either employees, teachers, students coming back to work, the darkest orange here, the likelihood of having 10 infected people come into school in that first week. I think our schools are taking strong efforts to have distancing, to have masking. But again, the risk at the school comes from the risk in the community. And so that's why it's so important for vigilance within our communities at every step there. We have started publishing the risk, like for the zip codes for school districts. And actually, so we're looking at new cases each 14-day period per 10,000 residents. Last week, the north central part of the state got a little bit redder than it had been. They've been relatively protected over time, but they had a number of outbreaks. Dover and Hector actually had a traveling revival come through, and that sparked a number of infections in those communities. So that's been a challenge. We are trending this data. I think on the next slide is a picture. Well, on our website, we're providing the the trend information for those school districts. There will be transmission at school. Schools need to be prepared for the infections. I think they also need to be and are doing the distancing, the hygiene, the masks. We will need to have some strike forces to go in and test students and staff when we have an outbreak. We've already seen some schools have challenges by all of their cafeteria workers had to go into quarantine, so they didn't have anybody to be able to prepare the meals. We're trying to have this be data-driven and public discussion around these decisions going forward. I think I'm almost to the end. Michelle, what do I have? We've got to find this balance of breaking the transmission of the virus through our public health strategies, learning how to live in our new normal and get our businesses back to work, get our kids back to school. And that's going to take, sacrificing some of our personal liberties by wearing a mask and recognizing that we have a responsibility to each other to help have a societal response to this new risk. So with that, I think I'm through. I'll be glad to take any questions. I fear this virus is going to be with us for a while. I think we're going to be here in this situation for the next several months, probably well into 2021. Each week we put out an update with all of our new data, all of our new findings. So if you'd like to sign up for our newsletter, please do. It comes out on Thursday afternoons. And again, we're here to learn and to disseminate, and look forward to your questions and answers. So with that, Leslie, let me shut up and turn it back over to you. I'll be glad to answer any questions that I might be able to.
Thank you so much. We really appreciate you sharing all of those resources. I dropped the link to the website and to the YouTube channel where you all can view those updates each week as well in the chat. And we're a little bit constrained on time. So if anybody has some really quick, one or two really quick questions that you can ask, I'll take them. But if not, we can certainly
feel free to email us and we'll be glad to respond accordingly.
Yeah, we'll make sure that we share all of Dr. Thompson's contact information with you all as well if you have something a little bit more specific or involved. So, all right. Well, then I'm going to go ahead and pass it to our next speaker, Abby Hughes Holsclaw, and she is the Senior Director for the Asset Funders Network, and is going to talk to us a little bit more about how COVID-19 has specifically affected ALICE individuals and families in Arkansas. And Abby, I have made you a co-host so that you can share your screen, but would you prefer that I advance your slides for you?
Go ahead and I'll just say next slide, if that works.
Yep, that works. So let me just get pulled up that.
Well, while Leslie's doing that, let me just say thank you for the invitation to be with you all today. I'll try to move through this fairly quickly to give us a little bit of time in case you have some questions. But again, thanks for inviting me to be with you. If you have any trouble hearing me, let me know. I was thrilled with the opportunity to be part of the summit today and talk to you and introduce you to Alice, who I'm going to talk a little bit more about. I am a consultant based here in Little Rock, Arkansas. My firm is Proper Southern Strategies, but I actually wear many different hats. One of which is I am the Senior Director for the Asset Funders Network, a national network of philanthropy across the country. And we have a regional chapter here in the state of Arkansas, the Arkansas Asset Funders Network. I encourage you, when you have time, to look at assetfunders.org and learn more about the research and the work that AFN is doing. But I have the great pleasure of working with these funders, and part of that work has included work around ALICE. So if you'll go to the next slide, Leslie. So today I wanted to talk to you and share just a couple of things. One is a member of the Arkansas Asset Funders Network is the Winthrop Rockefeller Foundation, and I'm going to tell you a little bit more about the Winthrop Rockefeller Foundation's Equity 2025 journey because it very much relates to Alice. I'd like to give you an overview of Alice, talk to you about how Alice is being leveraged, offer some specific COVID-19 insights into Alice, and then invite any questions that you may have. So Leslie, if you'll go to the next slide. So let's start with the Winthrop Rockefeller Foundation. WRF was a founding member of this Arkansas Asset Funders Network. And essentially, the group came together because there was a feeling that there's only a limited amount of philanthropy in the state of Arkansas. And if we were doing things and being in conversation around a table with one another, we could be more strategic, leverage our dollars, and make them go further. About a year ago, the Winthrop Rockefeller Foundation on its own went through a board journey to redefine itself, refocus its mission and vision. And what you see here before you today is the equivalent of that good work, where they really elevated equity by 2025 as their mission to relentlessly pursue that. And not just pursue equity, you know, from a 50,000 foot level, but to focus in on economic, educational, social, ethnic, and racial equity in particular. So if you'll go to the next slide. So these next couple of slides, and I won't read them to you, we'll go rather quickly. It's really an opportunity for the foundation to elevate what it means by economic equity. I think Leslie will be sharing these slides with you, but I wanted to offer it as a basis for, if you'll go to the next slide, this is the economic, the educational, and then the next slide will show you their social, ethnic, and racial equity. The foundation itself, as it was developing this work, stepped back and said, you know, how do we know where we are as a state along all of these lines? What's the research tell us, so that we have a baseline to see by 2025, have we moved the needle? Did we make change? And so they invested in 3 different reports, 3 different, you know, significant research reports, one of which is ALICE. And ALICE means asset limited, income constrained, employed. And we're going to talk a lot more actually about ALICE, but that is how ALICE came to be in Arkansas. And that is that the foundation needed this information to help guide it as it moved forward. So next slide. So part of what I wanted to really kick off the conversation about ALICE with was to ask you all to close your eyes. So, and I can actually see you. So for those of you who I can see if you're participating. But I'm going to ask you to close your eyes, and I'm going to ask this question, and I want you to visualize, when I say the word poverty, what picture do you have in your head? So take a minute, focus in on the picture that you're visualizing. And Leslie, I'm going to ask you to go to the next slide. I have a feeling, so open your eyes, that many of you pictured something like what you see on the screen. The person who perhaps is standing at the corner of Mississippi and Cantrell, if you're here in Little Rock, with a sign, or off of the 630 exit by the zoo with a sign, you know, some of your major thoroughfares in Conway, etc. Abandoned buildings, individuals who might be on various street corners on benches. So go to the next slide, Leslie. So there's a couple of things that I want to point out about this, and that is these images, in fact, tell us the color of poverty, the character of poverty, the reason for poverty, and creates a them of poverty. And I want to pay tribute to Sarah Bishop at Orchid Communications that does a lot of amazing narrative change work. And if she were with us today, you know, she would talk about how in our heads, we have these images when we say poverty. like it or not, this is where we instantly go. And even well-intentioned individuals, perhaps still have these very similar reactions to poverty. And Arkansas is certainly not absent of those. So if you'll go to the next slide, Leslie, I want to show you in the state of Arkansas that these are often the pictures of people, Alice, if you will, of folks who are in fact living on the margins of or right below the poverty line. It's your home health care workers. It's, construction workers. It's your bartistas and folks who are working in the restaurant industry. It's often teachers' aides, even teachers themselves. And that, and we're going to get into it in a moment, but in fact, in the state of Arkansas, over 41% are ALICE. That's asset limited, income constrained, and yet that key word, they're employed, they're working, sometimes working more than in fact one job. So if you'll go to the next slide. So a little background on the ALICE report in the state of Arkansas. And again, you heard me mention that the Winthrop Rockefeller Foundation commissioned ALICE in Arkansas and has honestly gifted it to everyone, has gifted it to you all, has gifted it to the United Ways across the state. The data is in fact, for anyone who would like to leverage and use the ALICE information. But ALICE in the state of Arkansas is not the only report that exists. Next slide. Let me talk to you a little bit about who ALICE is. So ALICE is right above that federal poverty level, often about the 200% above federal poverty. An ALICE report gives you county by county data that dives into the essential part of what it takes to survive in the most basic of ways to meet one's basic needs. They're often in low-wage jobs. So again, they're your cashiers, they're the healthcare workers, security guards, office administrators. The budget itself that makes up the ALICE budget takes into account no room for emergencies, which we all know emergencies never happen and we don't have to plan for those. I mean, the current pandemic is just yet one massively long emergency that we've all been enduring. Nor does it take into account that ALICE is wanting to invest in his or her, and I mention that because ALICE is not necessarily only a woman. ALICE is also a man, and his or her children or his or herself's education, home ownership, or retirement. Next slide. So I mentioned this earlier, and that is 41% of Arkansas falls into this ALICE category. You see here that 59% of our state finds itself above the ALICE threshold, 24 are ALICE, and 17 are actually living below the federal poverty line. So if you'll go to the next slide. So here is a snapshot of what goes into every single, not just the state number, but also all of the county numbers. You're going to see the basics: housing, childcare, food, transportation, healthcare, technology, a line for some miscellaneous taxes coming to a monthly total, an annual total, and then breaking it down into what wage would that take to get them to that ALICE threshold. And this is done for a single adult, 2 adults, 1 infant, 1 preschooler, taking into sort of the varying budget calculations that one would have to make. And so again, I'm going to show you in here a link to all this information. So whatever county or jurisdiction that you're sitting in that you might have a particular interest in, you can go in and look at your own ALICE data and play with that. If you'll go to the next slide. So a couple of things for those of you on the line who are researchers. These are where the numbers come from. just so that you have a sense of how we're coming to quote unquote the basics. If you look across the country, there are a variety of these sort of basic level budgets that folks have put together. Alice is one example. Alice originated with the United Way of Northern New Jersey and has spread to, I think, over 30 something states. No, wait, 21 states, I think is where we are now. And so again, perhaps those of you who aren't researchers, this is more information than you would want, but I think it's helpful for you to see where the information is coming from. That is also why you see some of the information being dated. So for example, you'll see on here that Arkansas's budget was built on 2017 numbers, and it's because some of this information takes time. I want to mention that because we know that pre-pandemic, 41% of Arkansas was Alice. You can only imagine where we are now. So I think that that matters as we look forward, and it'll be interesting to see perhaps how things change with folks who are Alice and or below. Next slide. So you'll see here on this slide that the cost of living obviously is outpacing our wages. So you see for the single adult and the family of 4 that that's what it takes to be at an Alice threshold. And you'll see only the registered nurses are above, for a family of 4, above the Alice threshold. You can see across the line here the annual wages for each of these specific job categories in our state. And again, think across this, how many have been impacted or affected by the current pandemic and have either been laid off and or the businesses have closed. Next slide. So when I asked you to close your eyes earlier and think of an image of poverty, I have to say that I've been doing this work for the Winthrop Rockefeller Foundation and the Asset Funders Network all of 2019. And when we released this report on March 10th at the state capitol, and literally that very week, I think that was a Tuesday, that very Friday, our entire state shut down. It had not crossed my mind at that point that Alice would be more apparent to me and to me personally through the pandemic than Alice has ever been in my entire life. As I would go to Kroger in my mask, and especially at the beginning with no protection equipment for the cash register worker, at Target, there was no, plastic barrier at that point either. Alice, him or her, is quite frankly a maintainer of what's been keeping our economy going, while all of us who have the ability to work from home have been able to keep our jobs and keep moving forward. So if you look here at the various occupations that often Alice would find his or herself, you'll see the medium hourly wages. And you can tell that, for the state of Arkansas, many of these positions don't pay enough to meet our Arkansas household survival budget that has been created. Next slide. In fact, more than half of jobs in our state pay less than $20 an hour, with our minimum wage being $9.25. Next slide. The other thing to take into account is Alice is everywhere in our state. And you can see that below, the darker the blue is the percent of Alice, the percent of people who are below the Alice threshold. So you see a concentration in the Delta, pocket of Southwest as you move to Northwest Arkansas. And you can see some pockets of our state where perhaps the economy is a little stronger. and or there might be higher concentrations of individuals, with post-secondary degrees or higher earning wages. I don't think for many of you that this, the coloring in particular, will be surprising, but I do think a takeaway from this is that ALICE is in fact across the state and truly impacting us all. Next slide. So I mentioned earlier that we're not alone. In the state of Arkansas, we are the most recent ALICE state to be part of this 21 state gang who has adopted an ALICE report. You can see that this whole work started back in 2007 with United Way of Northern New Jersey and has simply continued to snowball. Some states like Louisiana have recently released their 4th update to the report. So Arkansas again is new to the bandwagon, but we're there and joining with all of the other work that's been happening. Next slide. Here's a snapshot too of a breakdown of race and ethnicity, and that's another, perhaps myth in our state, is that ALICE is a person of color, is Black or Latinx. And in fact, the majority of ALICE in the state of Arkansas are in fact white. Either way, disproportionately, people of color in the ALICE category are in fact, disproportionately impacted by not only COVID-19, but also racial discrimination and all of the things that really we kicked off talking about in the summit today. But I wanted you to see the breakdown here of ALICE and the various, and again, you'll get all of these slides in case this is something that you may want to use again in the future. Next slide. And this was what I was mentioning, that Black households in particular are 50% more likely to be below the ALICE threshold. And this is no surprise to many of you if you're reading the headlines, that Black adults actually are also twice as likely to die of COVID-19 as other racial groups. And we mentioned this earlier too, that this is a product of our ongoing institutional racism and systems and policy changes that we hope to see in the future. Next slide. So all of this data, including Arkansas's, is at unitedforalice.org, and we perhaps can drop that link in the chat box as well if that's helpful for you all. And you can break this down by county. If you'll go to the next slide. So I did want to mention a couple of things. So I mentioned that I'm working with the Asset Funders Network. I'm having a wonderful time working also with a group of United Way folks across the state. Arkansas is unique. The ALICE report in every other state has been launched by United Ways. And because the Winthrop Rockefeller Foundation was on this journey for equity 2025, it gifted ALICE to our state, to our United Ways, but also to everyone. And so one of the opportunities that you all have is to use the ALICE data for your own visions, missions, and benefit to frame the work that you're doing and leverage this. So I wanted to mention a few ways that folks in other states have been using ALICE. They've been using it just for their own educational purposes to inform their own internal strategies, grant making, direction, programmatic work. They've been elevating ALICE's story to the press on social media. And a very important point here too is that in many instances, they've encouraged and helped coach ALICE to tell his or her own story and not speaking for ALICE, meaning Alice doesn't need to be rescued. Alice is actually working his or her rear off, but Alice having the opportunity to tell his or her story can be really powerful. So we're seeing that across the country as well. You're seeing it in messaging campaigns around annual fundraising events, corporate engagement, about how we help individuals who are working to survive but needing that additional boost. Community impact to drive strategy, as I mentioned. And then other ways that folks are using Alice is even with in their own grant making and or grant receiving, telling the story of Alice and the population that you may be trying to impact. If you'll go to the next slide. So a few just things that I wanted to point out about COVID. Again, this is 2017 data. And so you can imagine every single slide, I would venture to say the Alice statistics and data look worse. But as it relates to what nationally we have seen with the Alice population and COVID-19, I have some of that information. What I unfortunately don't have is how Alice in Arkansas specifically has been impacted. So if you'll go to the next slide, I think I maybe have two here. We're seeing that Alice workers are often falling into that essential category where they often lack the basic employee protections that others may have, especially at the beginning of COVID. I mean, I was struck, even myself, with my dishwashing gloves, because those were the only gloves I could find when I had to go in Target, the number of just checkers that were simply checking people out like it was a normal Tuesday. And then now you see the barriers and, you know, the corporate response, if you will, to protecting their employees. And I'm not picking on Target. I think this was widespread, but I think at the beginning it was very clear that the essential workers who, you know, for their own livelihood had no choice but to show up to work. We're seeing that business disruption, that Alice is disproportionately impacted. They're often hourly wage workers. They've got reduced hours and or no hours. Therefore, they've got reduced wages or no wages. We're seeing this across the state of Arkansas with our conversations about access to broadband and technology, that Alice is less likely to have access to the internet and difficulty working from home. They don't have the pleasure of working from home in a lot of the positions and roles that they fulfill. We're also seeing that illness and isolation are creating increased cost, as are transportation costs and trouble commuting. No safety net, no savings, no assets to fall back on often means no choice for Alice but to in fact show up to work. Healthcare is prohibitive. You might feel like you need to be tested for COVID-19 or various ailments, but you know, for lack of health insurance, you perhaps are much less likely to expose yourself or to go to the doctor. We're also finding that Alice, nationally, it's stressful. I mean, you've seen that it's the high cost of being poor. Brookings research from a long time ago that, in fact, you know, COVID is extra stressful for the Alice population, and the uncertainty is adding just increased burdens on Alice and Alice households. Next slide. And just a few more facts on Alice children that happen to also have families, that 38% of families with children in the US are below the Alice threshold. And you can imagine that this creates a precarious situation for childcare, school, and university closings. Alice household children have a harder time participating in virtual learning, where that has been a need, not only you know, pockets of Arkansas, but across the state. We also have seen, and you've seen this all over the news, the schools that have rallied to continue to try to get food to households that they know are food insecure, that those children rely on the breakfast and lunch that they receive at school. And you know, many Alice households would fall into this category. We can also assume that a delay in one's education is going to exacerbate the student debt, as well as the income opportunity growth of the future for ALICE households. And ultimately, having to work, having no choices are going to increase ALICE households, especially ALICE households of color, to increased risk of contracting COVID-19. And then finally, those business closures and lost wages ultimately mean, you know, an inability to meet financial commitments. We've seen that despite moratoriums, evictions are on the rise. Despite moratoriums on eviction, you know, past rent will ultimately still be due one day. And again, these are the households that are not sitting on the financial safety net that allow them to fulfill those obligations. Next slide. So I share all of this as truly an opportunity that if we're talking about real economic recovery, and we're talking about recovery across our state, not just in Little Rock or Northwest Arkansas, that we need to think about the financial vulnerability of ALICE households and how we create and build back better policy systems and work that help move these households forward. And so again, as you continue to think about those visions and images of poverty in your mind, remember that you're encountering ALICE probably multiple times a day, if not relating to ALICE yourself or within your own family. So Leslie, thank you. I hopefully am not too far over, and I'll stop there.
Thank you so much, Abby. This is really, really helpful information. I dropped not a real link, but just the text of the website in there in the chat, and we'll share this information with everybody after the event today. So thank you again for sharing this information, and that really is a great gift that the Winthrop Rockefeller Foundation has given the state. All right, so we are going to go ahead and move into our final speaker for this first half of the program. And so we have Mireya Reith, who is the Executive Director of Arkansas United, and they have so many wonderful things going on serving immigrant communities in our state. And we're really excited for you to be here with us today, Mireya, and I will turn it over to you. Do you need me to make you a co-host? Do you have anything you need to share?
No, I'm afraid not, and I'm so sorry, Leslie. I actually have a hard stop at 1:30, so
okay.
I will do my best. And actually, I think not having PowerPoint slides will allow me to highlight some of the points. But more importantly, I hope to engage in conversation if any of you all have questions about immigrants. But maybe, Leslie, if you could be so kind as to share my contact information in the chat. I definitely welcome this to be an ongoing conversation. So, buenas tardes, everyone. Good afternoon. As Leslie shared, my name is Mireya. And I'm the founder and executive director of Arkansas United. We're a C3 that we are now going into our 9th year here in Arkansas with immigrant resource centers in Springdale and Little Rock. But most importantly, we take pride in the base of 800 immigrant workers that we are proud to call our members, many of which are ALICE workers that was just being described by Abby, many of which, we will be honest, don't have status or come from mixed status families here in Arkansas. And we come now from a strong community organizing background and base, and are proud to boast 7 membership committees across the state that are promoting civic engagement across Arkansas, lifting up and fighting for immigrant rights, and working at the local, state, and federal level to try and change policies. So I will say I also bring to this conversation the lens of state agencies. I'm also extremely proud to hold the position of the first Latina to hold a state office here in Arkansas. I just finished 7 years on the State Board of Education, where I was the youngest person in state history to chair the state board. And so definitely identified systemic issues at that time, ones that we're now seeing as well in our health industry. But more than anything, I hope to land today's conversation at opportunities for all of us to work together to fix those systemic issues and work in collaboration. So as I know Abby already said, and I just want to reiterate, the disproportionate effects of COVID on the immigrant community were indeed predictable from the data that she shared. But I also want to hopefully reiterate that they were preventable. And we definitely have the opportunity here in Arkansas right now to correct from some of the lessons that we've learned thus far. Just to give you all a sense, when we really, the numbers that are grounding the urgency and this conversation, we really saw the uptick in cases of immigrants, especially in the Latinx and the Marshallese communities around mid-May of this year. Where I know to some that may have been a surprise, again, to reiterate, our immigrant workforce is our essential workforce in Arkansas. Many of our immigrants never stopped working, even when COVID, and as Abby talked about, the privileges or the lack thereof that many of our families did not have, right, in terms of staying home and keeping the food supply chain going in this state and in this country, really set us up for the perfect storm here in Arkansas. And that uptick was actually measured by the Department of Health on May 20th for the first time. And we really saw that the trend did not even begin to subside until about mid-July. At the height of that 2-month period, about 60% of new COVID cases were Latinx and Marshallese. And for any of you all that may be familiar with Arkansas demographics, our state is not 60% Latinx and Marshallese. We're actually at about 11% of the population. And so that was an extremely worrisome trend, one that didn't just garner the attention of our state officials, but even the CDC who arrived to Arkansas because the effects were so disproportionate. And I do want to say that in the CDC's visit, they identified that at least 37% of the cases of the Latinx and Marshallese community could be tied to the poultry industry. Now, the purpose of their visit wasn't to look specifically at that. And so those are some policies I can talk about from our direct work with employers. But we do see a correlation once again between the essential workforce and the rise in those cases. Currently, overall, where we stand today, the latest data from the Arkansas Department of Health, which goes back to September 2nd, just because it takes them about 2 weeks to validate numbers and new cases. But about overall 21.6% of COVID cases are Hispanic. So that's about 13,430 individuals in our community who've been identified with COVID. 421 of them are currently active. And we represent about 7.8% of the deaths in Arkansas. So again, I hope those numbers make the case about why this matters for Arkansas and our communities. I do want to say we as Arkansas United started to get a preview of some of the health and systemic issues, actually just dating back to 2019 with our work with the state legislature around deferred action for childhood arrivals and our DACA students. So students that may not have formal status in this country, but came here at a young age, have all completed many requirements, of which being in school or working is one of them. And a tremendous pathway was open to them to get work permits back in 2014 from President Obama. But shortly after that program was launched, we came to realize here in Arkansas that to get a professional license, you have to be a citizen. And so we had about 10,000 individuals, many of which I know attended your schools. I know we have Hendrix and UCA represented here. And these were individuals that were barred from the ability of getting a professional license. And that included as well in our health industry, and really came to a head in the summer of 2018 when some DACA students that were sitting down for the nursing exam had already paid for their whole degree and everything, and were told that they had to leave the room because they would not actually, if they passed the exam, be able to get licenses in Arkansas. And so that led us into our first journey as Arkansas United into the healthcare system. And I will say this, we have a workforce crisis in the healthcare system here in Arkansas. It's not just nursing, but it's more broader. And there is a cultural competency issue, right, in terms that there is not representation in our healthcare workforce that aligns with the demographics of its state. There is a capacity issue in that we're not bringing people into the workforce pipeline for the healthcare system that aligns with the demographic of our state. And then on top of that, Arkansas is one of only 3 states that we came to learn through that legislative fight that is still an English-only state. We actually, by law, are not allowed to put out information and put resources, state resources, toward translating into other languages besides English. And those are really efforts that come to fruition through private endeavors, or where maybe federal resources can be leveraged because of civil rights considerations. And so, and then we were also, and this literally happened about 1 week before COVID. Again, we were just starting to really build up this relationship with the healthcare industry, track those DACA nurses, see where we could go to next. And it was actually an academic at the University of Arkansas Medical School, Hispanic herself, that started raising the red flag that in here in Arkansas, our health data was not getting disaggregated by ethnicity and race. And actually that was also applying to research, that there was not specific research or grants that were being sought out to specifically look at different demographic and race implications, and that this could become and pose a major issue if there were to be a health crisis. And that really felt like writing on the wall for us. I admit we were in a sort of a bubble. We're proud to represent Arkansas in several national coalitions. A lot of our peers across the country were shutting down, and we're like, oh, we're Arkansas. You know, we just, we'll probably be fine. You know, no major airports. You know, we're going on as life as normal. And I remember saying those words in that evening, then watching Mayor Scott in Little Rock say that he was shutting down his city, and that here in Arkansas, we were not going to be in a bubble in this regard. And so because we're an organization that does civic engagement, has been deeply involved with our decision makers, again, we know that our decision makers don't reflect our general population here in Arkansas. Again, I'm the only Latina to hold state office in our state, and I've not been replaced since I stepped down from the state board. And so one of the things that we looked at early on was who were going to be the decision makers on COVID. And I will say that in looking at those early committees and commissions, there was pretty much no individuals of color that were getting appointed into those major task force. And as federal and state funding were looking to be designated, we looked at who were the demographic composition, again, of those commissions and decision makers, and saw almost no individuals of color. If there were any, there were some African Americans, but we didn't have any immigrants in those early days. And so we knew, both with the systemic issues and not having the voice directly in the table, that we were going to have to do some serious work from the onset to be able to bring attention to issues. And I will say it took about 1 month from really the start of the crisis here in Arkansas, and starting to see that seriousness before we got our first disaggregated data. It wasn't until early April before we even knew, and the early disaggregation was black and white. It took us well until mid-April before we had any disaggregation related to the Hispanic and Marshallese community. And I will say it was for us, it was a really tough conversation to have with our community, because they actually thought there weren't Hispanic cases because it wasn't coming out in the news. They didn't realize that it wasn't because the state wasn't measuring that data, and the different entities weren't systemically collecting it in a way that would let us do something about it. And so that was one of the myths that continued to be propelled until everybody understood the impact it was having in the community in mid-May. So in March, I am proud to say, and this is one of the things that we do hope ends up being one of the lessons learned and hopefully standing corrections. But there is a disconnect between state government, and I would also say this applied to the Department of Ed and my time there, and community-based organizations who are the social influencers connected on the ground and having that day-to-day work and relationship. And the health department only had a handful of individuals that identified as Latinx or Spanish speaking. And they were so busy early on doing all the translating and interpreting, they barely had time to get out in the community. And it was some of those individuals that reached out to us. And in that process, I really do have to celebrate the Department of Health and some individuals who had the foresight of trying to bring some of us together who were working both within the department, but outside the Department of Health. And they created what's now today called the Latinx Stakeholders Group, which is a standing committee that's meeting weekly on Thursdays and represents over 80 organizations, Latinx-led and Latinx-serving across the state, who's talking with directly our state officials in regards to sharing of information. It's where we've been able to flag issues that we've confronted along the way. And at the same time, try and identify collaborations, especially in those early days around testing and a lot of work that had to be done there. Another thing that happened that again, we continue to hold some hope for was the creation of a health equity response team. This was an effort sponsored by Senator Ingram, who was looking especially to the African-American community that he largely represents, coming from a Delta community, but saw the broader need, and without having that data early on, said that somebody had to bring attention to the health equity issues. And so he brought together a team that represented some of us nonprofits, UAMS, the Arkansas Minority Health Commission, and the Department of Health. That in turn, I'm really proud to say tomorrow has a proposal that's going to go before the CARE Steering Committee with some programs, but more importantly, looks forward to working with our governor and our Department of Health to bring forth hopefully some policy solutions in 2021. And then when we did see the peak in May with our community, I do want to say here in Arkansas, one of the things that we've been proud as an immigrant community is to have direct impacts and direct access to our employers. And so where we do think it's an ongoing conversation and we can't talk about health equity issue without talking about workers' rights issues. We have had access to lift up some of those questions, and where again, we think that there's still a lot of room for improvement. At the very least, some of our major employers, especially in the form of Walmart and Tyson, really did do some of that outreach to see how we could work together to address some of the barriers that the CDC was really trying to lift up for us in regards to preventative behavior, in regards to unwillingness of our community to participate in testing, and a lot of confusion around testing in regards to the community education. And they themselves played a role in the resources. I will say a lot of our early resources that is now letting us to do community navigator type programs and get services has actually come from the corporations up here as a first step, and in closing some of the gaps that we have continue to see at the state level. So some of the lessons that I really want to be able to bring in this space, knowing that others of you as well are working with our vulnerable communities and as philanthropy. I know that this is going to sound so simple, but for us, it's been so important to remind with COVID, you can't silo races and ethnicities as related to health, right? This is a perfect example of how the health of one community is directly interconnected to the health of another. And that's why it's so important for us to get rid of these systemic issues that lets us be able to offer equitable health solutions to everybody. Also, I know that right now we're in a moment where it may be easy to look at some of the criminal justice work and this moment of attention on systemic racism as somehow being separate from public health. But we actually think the city of Fayetteville did it right in declaring systemic racism as another public health issue. And we need to be able to look at the intersectionality between more of those deeper. A third point I do want to make, because I know many of you are nonprofits, but maybe don't do direct advocacy. We can't silo out programs and policy. The reality is we have to be willing as service providers to also be able to engage in the policy process. And our policymakers, we cannot assume that they know what issues and barriers we're confronting. And what I can tell you in moments like this, they have no capacity to even think about reaching out to us. They don't have those embedded relationships. And it's so important that we unite as service providers to make sure our elected officials understand what systemic barriers we confronted, why those issues have to be addressed, and challenge them to do so, especially in moments like this, where we can actually make that demonstrable case in a deeper way. Just to give you a perfect example, the Social Security number requirements out there on a lot of this federal funding, our immigrant communities aren't going to qualify. And now it's not even just that one person in the family may not have Social Security. Now they're requesting every single family member have a Social Security number to be able to apply for any of these CARES related programs. And that really is blocking out a lot of opportunity and possibility for a lot of our children. Another reason, again, with the systemic issues, right? The governor, in issuing more resources for contact tracers, issued a mandate that at least 50% of these new contact tracers be bilingual. I'm so sad to say that the Department of Health has been able to hire less than 12 bilingual individuals coming out of that effort because they don't exist. The individuals trained and ready to go in the workforce that could do this work don't exist. And guess what? They're actually getting paid more money to work at Tyson and be essential workers than they are to be bilingual contact tracers in this moment. Again, we have to look at these issues as interconnected. And the last point I really want to make to this group, and I hope you guys will appreciate me in saying this, that language matters, and it's not just a Spanish or English. One of the things now, working with the Department of Health and working with the Department of Ed, I celebrate the education journey and all the knowledge that is in those two agencies. But I will say, sometimes speaking to those experts, you realize that they have forgotten how to speak to everyday people in language and terms that matter to them. I am proud of my own Ivy League education, but I was lost my first 2 years on the Department of Education and on that state board. And when I went to the Department of Health and worked here again, I constantly asked doctors, no, speak in normal terms, speak in plain language for me, because I need to be able to communicate. Not that it wasn't just understanding, I needed to figure out what were those plain terms that we can then translate to our community. And I will say that is still where we're getting it wrong. There's so much money and resources that are being spent right now on videos that are not being seen. And beautiful diagrams that use terminology that will never mean anything to the everyday person in our community. If we want to be able to get it, we have to also really invest in and lift up to be change agents, those social influencers, the church leaders, the nonprofits, the local DJs, in ways that let us all be working with it together. And I'm here to say on behalf of the immigrant community that we want to be change agents, that we stand ready to collaborate with our state, but we are also going to need to see some of those systemic changes to make to happen. And so I'll stop there, but to say and just ask everyone, if you're interested, please look at the CARE Steering Committee tomorrow. That's going to be a real test about all of us getting more resources. The state has run out of a lot of resources. And so if you care about what's going on in this moment, I really do encourage you, reach out to your legislature and encourage the legislature to continue to passing some of those resources so we can move forward. And again, to just show you how these things will keep repeating, Hispanics are not participating in the vaccine tests. And Marshallese are not. And so just those same issues we have with testing, we're going to find with vaccines if we don't get it right now to engage the right people, the right messages, and the right collaborations. So thank you so much for your time. And I appreciate all of you and your partnership and for what you're doing. And if there's opportunities to work together, I hope we can do so. Thank you.
Thank you so much, Mireya, and thank you for all the heavy lifting that Arkansas United has been doing, as well as all of your partners with that Latinx stakeholders group. That's really, really great information for everyone on this call to hear, and we appreciate you sticking with us this afternoon. So, thank you. All right, so we are ready to hear some local perspectives from here in Conway, but I need to give everybody just a quick break. So I know Jennifer Welter and Spring Hunter and Phil Fletcher are all here ready to share their quick perspectives with you as well, but I'm just going to ask everybody to hang tight for about 5 minutes and go take a break, get some snacks, do whatever you need to do, and we'll see you back in 5.